Welcome to the Central Raid podcast. My name is Ryan Ross and I will be your host as we talk about all things radiography. Here we will focus on X-ray from my somewhat unique perspective as a former surgical imager, compliance coordinator, manager and now an educator. Please like and subscribe to make sure you do not miss out on any future episodes and conversations with surgeons, medical physicists and industry leaders. Please feel free to email me at ask@thecentralraid.podcast with your questions for upcoming topics or to provide feedback on the content. Now, enjoy the show. Hi everyone, and thanks so much for coming back to the Central Raid podcast. Before I go ahead and get started, I was hoping you could do me a huge favour. Please go ahead and like and subscribe to the show so you can get the notifications. And if you're on a platform that allows it, please go ahead and leave a review to help others find the show and also to help that algorithm do its thing. So today we are going to talk about my passion project of C-arm, and hopefully we'll discuss some reasons why it seems to be so challenging and why so many technologists find it so stressful in the OR, essentially to the point where they do not ever want to set foot in those blue scrubs ever again. Now, hopefully by the end of this, you'll have a sense that I absolutely loved my time in the OR. I felt such a part of the patient care team. My skills felt valued. The surgeon had their role, I had my role, and I felt accomplished. And I would finish at the end of the day feeling as though I had done good work. And that wasn't always a feeling that I got when I was in routine X-ray. One of the major reasons why I feel that technologists really struggle with C-arm is because there is no education. There is a lot of ignorance to the skill that is needed and really possible in some of these more complex trauma cases. Now, when I first started at my level 1 trauma centre, I had about 2 years of C-arm experience, probably more if you include my time as a student where I'd done a lot of pain management. And then as a technologist, I'd done a lot of spine work. So I was what I felt fairly comfortable and very competent. However, once I got to that level 1 trauma and we started doing IM nails and pelvis and acetabulum and pedicle screws, I immediately knew that this was a whole new ballgame and I would really have to step up my game. Now, I was coming from a background in music where if I wanted to get better, I had to practice. So I brought that mentality to C-arm. And how was I able to practice C-arm? Well, I would observe a lot of the cases and then I would take the requirements of the images, the type of movements, and then I would just find a space where I could set up a C-arm, obviously not exposing, but I could just familiarize myself with the movements, getting a feel of how the C-arm moved, trying to manipulate and perform that case in my head. And then the more that I practiced it, the more comfortable I got with those hard cases. But then I also saw that there was more of an actual teachable skill to the C-arm. But we'll probably come back to the mechanics of it a little bit more. One of the first things to talk about is C-arm terminology and how varied it is across different services, different hospitals, different healthcare providers. And I just was having this conversation, well, I've had this conversation several times, but this was with a pain doctor based out of Boston, and their terminology, again, was completely different. And as a technologist in a facility that had 75 operating areas and surplus of 200 surgeons, we had to become a translator to the different types of terminologies that they were using. Some would say push in, some would say boom in, some would say lateral, move medial, and it was very varied. And then you would also have some surgeons who would mix up their language. And in those instances, pretty much all instances, when you are locked in and involved in the case and really paying attention, the movements are almost understood before they're required. So when you hear that surgeon say other view, you instinctively know what they're looking for. And the level of precision on the imaging in the OR was far, far, far greater than I ever had when I was a departmental technologist. Because I would take my images and, there is a certain amount of give that we or play in the image that is a range of acceptability. But when you are in surgery, especially orthopedics, and you are looking to perform permanent fixation, you want to have that anatomical alignment and the view absolutely spot on. And if those surgeons don't get the view they're exactly looking for, be sure they will absolutely let you know. Maybe not so in as many words, but their tone will change, the way they stare at you, you will get a sense of their size and the frustrations. So how can we overcome that? So where do we think the surgeon's frustration comes from? You know, some surgeons have different ways of expressing, but it's really, I don't really blame them, because when they call for x-ray, they are expecting to have an imaging expert walk through that room. So really, if anyone is to blame, it is the entire field of radiography, because we do not appreciate the skill that is required of us by others. Now, because these surgeons, they're working in orthopedics, they're working in vascular, they're working in urology, and we just don't get that precision level of education. Yes, our positioning textbooks talk about it, but the actual need and requirement is not really enforced as we go through our training. And again, it's that coming down to that having a range of acceptability, but that doesn't fly in the OR. And then secondly is we don't really get adequate training on the machines that we use, and more specifically, how those movements really impact the anatomy on the screen. Because the C-arm really, in many instances, works in reverse for what we are used to as technologists. And what I mean there is that we are used to observing our corrections from the perspective of the X-ray tube, whereas on C-arm, we're really observing the field from the receptor side. So I asked the question earlier, how can we fix this? And I really think that we have to look at the schooling. So as we go through X-ray school, being able to work on C-arm skills in the safety of our lab, if the schools have access to the resources, that's really where this has to take place. We have to instill a sense of confidence and understanding so that when students or new graduates go into the field, they actually have an idea of how the machine works, or at least how to manipulate the central ray to be able to observe the anatomy the way that it should. From what I observe, a lot of institutions that are fortunate to have a C-arm, it's definitely underutilized. And the basic principle of that is how to connect up the viewing station to the actual base of the unit. A quick description of what the locks are or how the functions are, but that really is it. There's no simulation of cases. There's no manipulation or testing of beam geometry. And that's something that I really focus on a lot with my students. Obviously, C-arm is a huge focus of mine, so I kind of shoehorn a lot more C-arm into our curriculum than most places. So we usually start off with single plane imaging, such as urology, and then some basic spine where we do APs and laterals, and really focus on lining up the spinous process, getting those end plates really lined up. With the urology, we work on accuracy of moving from the bladder up to the kidney and then following it back up from the bladder to the kidney as if we're chasing up a stent. And then for the students that seem fairly capable and wish to pursue more, we do optional classes on a little bit more challenging orthopedic work, which are not, they're still AP and lateral, but now they are AP and lateral at an angle. And that just requires a different process or a slightly different methodology that I term the image fulcrum. And that's a term, the fulcrum, that's been around for a long time, especially from the practice of tomography, but using it in C-arm. So the image fulcrum is the intersect of those two planes. So it's a point in space where you would look to place the anatomy so that when you switch from one view, whether it be an inlet to an outlet or an AP to a lateral, that you don't have to make any other changes, because when you go back and forth, your object of interest is centered in both planes. So when you're doing those challenging cases like your SI screws, etc., being able to just shift back and forth without having to make any other adjustments other than your tilt, it really is the most efficient and the most reproductive form of imaging, and that greatly reduces the number of exposures, which then is less dose for the patient, for the personnel, and typically case times are reduced. And the start-out study that I done on this, we were able to show that dose was impacted with a reduction of up to 50%, and imaging time, so just the actual imaging time going back and forth to reproduce, was cut by about 80%. So these are huge savings. So access to resources for schools and colleges is definitely a sticking point, because this equipment is expensive. You know, and $25,000, $40,000 for a C-arm is not really a justifiable budget item for a lot of places. Time is also another scarce resource. It takes a lot of time to actually perform labs on C-arm, because you don't want to do these in large group settings. The labs that I host are in about 3 to 4 students. So if we have a cohort of 20, 25 students, we split that up into 5, 6 different sections. So it can definitely get timely. But again, because that's a passion and I know the frustration of the surgeons, I feel that it's something that is very valid of my time. So I definitely make as much time for these labs because I really, really value them. And then also the knowledge and the skill of these accurate or precision-based cases. And really, unless you have been in those level 2, level 1 cases, it's very hard to understand that level of precision or the real impact. So you have this entry-level skill, which we should all have, but then there's this second tier that really make a huge difference. And that's personally where I feel the distinction has to come in, that is worthy of an additional credential for surgical C-arm users or surgical technologists, because they add so much value in terms of their efficiency, their dose reduction, just bringing case times down. The impact on patient care is huge. I even had a conversation with one surgeon who said that depending on the X-ray technologies that they have, their plan may change. If they only have 1 hour to perform a case and the technologist just can't get the views, they may have to just position an X-Fix or stabilize the joint until such times as that patient can come back when they're more stable, and hopefully a more competent technologist is on. And when I heard that, my mind was absolutely blown, because as experienced as I had been in those cases, I just had no idea of the impact that was felt to the patient, unbeknownst to the patient, but obviously it was felt by the surgical team. So for an X-ray student graduating from X-ray school, what should be entry-level skill? For me, it would be single plane imaging, so your ERCPs, bronchoscopies, line placements, or urology cases. They are all entry level. There's not a great deal of C-arm manipulation required of those, so competency in that should definitely be one. And then you could take it one step further by doing more basic spine work. So just being able to recognize a good AP, PA, lumbar spine, for example, and being able to get a good lateral, being able to identify when you have to do corrective WAG. So I think basic 2-plane imaging and single-plane imaging should really be the standard for student radiographers having a good understanding. And hopefully the schools can implement some form of practice where these can be performed and practiced. Because remember, we don't get to practice these until we're in a real situation with a real surgeon, under real anesthesia, under real pressure. Now, I'm not saying that this is not a great way to learn, because you absolutely have to fine-tune and get used to that environment. But having observed, surgeons are mostly hesitant, especially in the challenging cases, to have a student radiographer in their cases, because it's very hard for the technologist to describe what's going on to the student, because it's a distraction, or sometimes that technologist isn't really giving great advice or isn't fully aware of what's going on. You know, I mean, there's obviously some phenomenal technologists out there, but we're now in a staffing predicament where we have new graduates going in and performing these otherwise experienced tech-only cases. And again, it's not fair on the new graduates and it's not fair on the students. And it's not their fault, but they're the ones that feel the brunt of it from the surgeons. And it's the lack of training going into the field. And I think if there was that branch of advanced practice radiographer, or however we look to term it, that almost sets a bar of expectation based on the surgeon. So if they see that you are not one of those, or they can request someone who is a little bit more credentialed and more capable of the case. I remember having another conversation with a surgeon, and when we were talking about the compensation relative to skill within imaging, they felt that C-arm technologists, especially in their complex ortho cases, should have been the highest paid because of the benefit that they bring to the case, to the patient, and the time savings. They can effectively have cases halved in their time, or the room is opened up for additional patients to get treated that day, which when you're in a trauma facility, that is a huge advantage of having highly skilled and well-compensated technologists to keep those highly skilled technologists in the area. For those of you that may have seen me on YouTube or LinkedIn, I have developed this little C-arm training phantom, which has a lot of these common angles. Obviously, every surgery is different, but there's kind of generalistic angles that we are typically asked to take images of, whether it be a surgical lateral, where you want to be between 35 and 45 degrees wide to the head. Inlet, outlet, maybe something like 20, 25 degrees inlet, 25, 30 degrees outlet. And then your obliques set at 15, 30, 45. So these are all built into this phantom, and they are viewed as perfect circles. So when your geometry is not lined up perfectly, you get instant feedback from that imaging block. And it's just called the C-arm training phantom. And I can put a link to that in the show notes, but it just gives you that immediate feedback of your precision, and hopefully it gives you a sense of awareness on how to make logical corrections so that you can demonstrate and be reproducible in your imaging. So I'm going to go ahead and wrap up there for now, but I just want to bring to your attention that I have a couple of really great interviews on the horizon for the next couple of episodes. I'm interviewing a C-arm technologist who's been an OR tech for about 25 years. And then I also have an interview coming up with an orthopedic trauma surgeon. So hopefully both of those episodes will give some additional great information to this subject. And thanks for sticking with the podcast to this time, and hopefully I'll catch you on the next one. Thank you.